Hello everyone, welcome back on this channel. In this video, we will be covering hip complex entire topic in just one video. So I hope that you are ready and even I am also ready. And so let us complete this entire hip complex in one go with the beginning, which is the basic introduction. Always remember to write it in the answer while you are attempting 15 marker answer or a 7 mark answer. Be it any sort of complex, introduction should always come in the start. So hip complex is also known as coxofemoral or femoroacetabular joint, because femoro, that means it is attached to femur, and acetabular, as the articulating surface of hip bone is acetabulum. Then comes the mobility, so it is mobile in all axes and planes. Then comes closed kinematic chain. So hip complex or hip joint works in CKC, that means closed kinematic chain with pelvis joint. As you know that our hip joint is somewhat like this and our femur is like this, so it works in close proximity with this, as these both structures are attached. Then comes the power action. So the muscles around the hip joint have long momentum, as you might have learned in the anatomical pulleys, that the greater the distance of the muscle or the ligament, the greater is the momentum and the greater is the action. So to understand this point, you should be aware about the anatomical pulleys. Then comes contraction. Eccentric and concentric contractions of hip and pelvis muscle. So concentric means contraction and eccentric means elongation of hip and pelvis muscle. It withstands high compressive, high tensile and high distraction force. So this was our basic introduction. Now let us come to the anatomical background. So in the anatomical background, you should include the type of joint as well as the bones. So this is a diarthrodial ball and socket variety of synovial joint. In introduction also we mentioned that it is mobile in all axes and planes, which means that it is diarthrodial. Diarthrodial means it is freely movable in all axes. Ball and socket, as the ball is of the femur, head of the femur, and socket, which is the acetabulum. Variety of synovial joint. Then is bones. So it is formed by the articulation between head of the femur and acetabular fossa of the hip bone or the pelvis. Then let us come to the proximal articulating surface. So we are done with the anatomical background. We mentioned the type, bones. Now you should mention about the articulating surface, same to what we mentioned in the anatomy joints. So proximal articulating surface, cavity. So as we know, proximal articulating surface, which is near to the body, so near to the body is pelvis. So pelvis, proximal articulating surface is the acetabular fossa, or it is the cavity sort of thing which accumulates head of the femur. So this is the cavity of acetabulum on the pelvis, which is concave in structure. So it is deep in structure, so it is concave in structure. Part of acetabulum articulating with femur is covered with hyaline cartilage. So as we know that these acetabular surface is covered with hyaline cartilage, so yes, that is hyaline cartilage, and it is of lunate shape. So the structure of the cavity is similar to a lunate shape. Then comes the labrum. So acetabular labrum. So acetabular labrum is also a sort of covering around the acetabulum or acetabular fossa. Its functions are remembered by the mnemonic DAMP, damp. So D means it deepens, A means it accommodates, M means it maintains the contact between the head of the femur and the acetabular fossa, and it protects the slipping of the head. Deepens the cavity, accommodates the head of the femur, maintains the contact and protects from other sort of conditions. So acetabular labrum, it is wedge shaped fibrocartilage. It deepens the articular surface. It increases the congruency, means it increases the attachments. Then it maintains maximum surface contact area. So as we know that for hip joint, maximum surface contact area is there, as the cavity is deep of acetabulum. But if we compare it with the shoulder joint, the congruency or the surface contact area is less. So in case of hip joint, the maximum surface contact area is present. So joint is most congruent in closed packed position. Closed packed position is the position of any sort of joint in which it is most congruent, means it is the most safest position of a joint in which there are no chances or there are less chances of any sort of slipping or dislocation. So most congruency is present in the close back position of hip joint, or let's say in other joints also. So CPP or close back position for hip joint is full extension of hip plus internal rotation or medial rotation of hip joint. So you can try it by your own right now while seeing the video, and you'll notice the CPP position. So this sort of question is asked in 3 markers also. Then is loose back position. So close back position was most congruent, then loose back position will be least congruent. So the least congruent position for hip complex or hip joint is hip flexion, abduction and lateral rotation. So this position is known as frog leg position. I hope that you might have heard regarding the frog leg position. Then it is true physiological position of hip joint. So this LPP is known as true physiological position of hip joint. If they ask you CPP or most congruent, then you should write this position. If they ask true physiologic position or frog leg position or loose back position, then you should write these positions. I hope that you are clear with it, and I request you to make a chart of all the joints, their close back position and loose back positions. So you should classify them. Suppose this is hip, then this is shoulder and all other joints also, so that it will be easy for you to write in 3 markers as well as the long answer questions also. So now next is the function of acetabular labrum. I hope that you have learnt about the acetabular labrum in anatomy. If not, then we'll learn it now. So as I mentioned, it increases the contact area, it deepens the fossa to accumulate the head of the femur, then it protects. So D, protection, DP, then protection. In the protection point, we have that proprioceptive role in protection of acetabular rim. So it have proprioceptor sensors, so it helps in the protection of acetabular rim. Then it don't have load bearing properties. So acetabular labrum is a cartilaginous rim, but it doesn't have load bearing properties. Then it creates a negative intra-articular pressure. It increases joint lubrication. It makes a negative pressure to create a tight seal, so that the head of the femur and the acetabular fossa, they remain in a close proximity inside a vacuum. So if you can remember, I am connecting it with physiology. So what is the function of surfactant? Comment down in the comment section. So tight seal for femoral head and mobilization of synovial fluid. Then is orientation. So orientation of acetabulum is laterally, anteriorly and inferiorly. So anterior orientation is known as anteversion, and inferior orientation is known as tilt of the acetabular fossa. So these points will be covered in the further topics. Wait, if you haven't understood what is mean by anteversion or tilt. Then comes the extent of inferior tilt of acetabulum forms the roof for covering the femoral head. So as we know that the acetabular fossa is little bit inferiorly tilted. So if this is the acetabular fossa, so it is little bit inferior. So then this cavity is facing down, so it creates a roof. So this roof is created for the head of the femur. So as you can see, this is the roof. Then comes the inferior tilt. So inferior tilt, center edge angle of Wiberg or Weiberg, anything you say. I say it Wiberg. So center edge angle of Wiberg. They ask you in 7 marker question as well as in 15 marker question regarding this. So it is formed between the center of the femoral. So as you can see here in this diagram, this is the center of the femoral head, this is the head of the femur, and the lateral rim of the acetabulum. So the rim which covers the acetabulum laterally of the femoral head and the lateral rim. So this lateral rim ends here, so this line and this line. So here the angle which is created here is known as center edge angle or the angle of Wiberg. CEA means center edge angle. So it should normally be more than 25 degree. So children have less angle because the lower roof area of contact due to the reduction in the roof of area of contact. So in children what happens that the lateral rim, it doesn't cover the whole surface, so it ends like this, and the head of femur is like this. So area of contact is less, so their angle forms like this. So here angle like, so the angle is less for children. As you can see, I have demonstrated in case of children. So there are high chances of dislocation of hip joint in children, as there is instability of the joint. The roof covering is less, so there is high chances of dislocation. Now the applied part. Always remember to mention the applied part in any joint question. So the applied part of center edge angle is dysplasia, the condition in which the center edge angle is less than normal, means less than 25. There are two categories of dysplasia, definite and possible. So definite dysplasia means the angle is less than 16 degree. The angle is less than 16 degree, then 100% that person is having dysplasia. But if the angle is between 16 degree to 25 degree, then there is a possible dysplasia, means there is a possibility of the person having dysplasia. Excessive acetabular over coverage means the angle should be between 25 degree to 40 degree only. If the angle is more than 40 degree, then there is excessive acetabular coverage. So if it covers more sort of head or more part of head, then as we know that the degree of freedom for movements will be reduced. Acetabulum is placed anteriorly, there is anterior stability. So as we know that acetabulum is placed little anteriorly. You can see this in your atlases as well as in the bones, that acetabulum is little anteriorly. So if this is your body, then acetabulum lies little anteriorly, so it causes anterior stability. So this is known as angle of acetabular anteversion. So anterior stability causes anteversion, as I mentioned previously. So what is angle of anteversion? So it is line connecting the anterior and the posterior acetabular margin. So this is the anterior acetabular margin, this is the posterior acetabular margin. So this is the line connecting them both, and the line passing through the head of the femur in the transverse plane. So this is the transverse plane, so this is the line. So this is the angle of acetabular anteversion, so which is 20 degree. Then comes distal articulating surface. Now we have completed the portion of proximal articulating surface. Now we'll see distal articulating surface. So distal articulating surface by the head of the femur, that is convex. So head of the femur, it is convex and the acetabulum was concave, covered by hyaline cartilage, and it is circular in shape. Then head of the femur is placed superiorly directed upwards, anteriorly directed anteriorly, as acetabulum is also directed anteriorly, and medially. So it is directed medially in order to fit inside the acetabular fossa. There are two angles which are formed by the head and the neck of femur, which is angle of inclination and angle of torsion. So angle of inclination is formed in frontal plane, whereas angle of torsion is formed in transverse plane. So one by one we'll see. Firstly, angle of inclination, which is in frontal plane. So it is formed between the line passing through the neck of femur and shaft in frontal plane, as we look anterior to posterior in anatomical position. The neck of the femur. So this is the line which is passing through the neck of the femur and shaft of the femur. So this is the angle of inclination. You can see this here. See, this is through the shaft and this is through the neck. So this is the angle, this angle of inclination. So it should normally be approximately 125 degree. It is decreased in females as pelvis is broader. So as pelvis is broader, so the distance between the pelvis is increased. So as the distance is increased, this angle goes on decreasing, as you can see here how I am marking. So angle goes on decreasing. Then applied part is coxa valga and coxa vara. Make sure you draw such kind of diagrams in universities. So if the angle is increased, it is known as coxa valga. So there are less chances of coxa valga in females, as already the angle is in decreased position. So coxa valga, it disturbs line of gravity, increases stress, wear and tear due to increase of load. So as you can see that the angle is increased, so entire load is falling on neck of the femur, then is coxa vara. So coxa vara possibility is mainly in female. So in close kinematic chain, entire gait biomechanics is disturbed. So during these both conditions, the way you walk, these conditions affect the way you walk and your entire biomechanics is disturbed due to coxa valga and coxa vara. Then is angle of torsion. So angle of torsion is formed in transverse plane. So it is the line passing through femoral condyles. So this is the line passing through femoral condyles and neck of the femur in transverse plane. So this is the neck of the femur in transverse plane. So this is the angle of torsion. So it should normally be approximately 10 to 20 degree. In abnormal condition, if this angle goes on increasing, that is known as antiversion. So if this angle is increased then normal, then it is known as antiversion. If this angle is decreased, then it is known as retroversion. Understood? So in antiversion, the Craig's test or trochanteric prominence angle test is done to check antiversion. And in cerebral palsy, commonly antiversion is observed, in which the angle which should normally be 10 to 20 degree, it is increased to 60 degree in cerebral palsy. Then is its clinical section, lever arm dysfunction as moment arm of muscle is changed. So as the position of the joint orientation is changed, common sense that the moment arm is also changing, as on the joint and on the bone only the muscles are attached. So if this structure or this orientation is changed, the moment arm of the muscle will also change. So there will be lever arm dysfunction. So regarding the lever, you'll learn it in biomechanics or kinesiology first year. Then is muscle length tension relationship is affected. So this topic, length tension relationship, also you will learn in kinesiology. Patella squint and pigeon toe walking due to increased antiversion. So if this angle goes on increasing, then there will be patellar squint and pigeon toe walking. Kinematics. So always remember, kinematics and kinetics are two different portions. People forget about kinematics and kinetics and they often make a confusion, and in exam they create a blunder. So always keep in mind that kinematics, if it is asked in question, you have to write about the movements, and if kinetics is asked in the question, then you have to write regarding what is producing the movement. So it includes muscles, it includes ligaments and other structures. So now we are seeing kinematics. So kinematics, open chain kinematics and closed chain kinematics. So for hip joint, there are two kinds, open chain and closed chain. Whereas in shoulder joint, we have only open chain kinematics, as the movements which we do of hand, it is free in the air. But whereas when we walk or when we jump, the movements occur in closed kinematic chain or when we bend. So there are the closed kinematic chain. So let us look for open kinematic chain. So in open kinematic chain, femur moves on acetabulum. So there is the movement of femur on the acetabulum. Basic knowledge, movements, which are the movements: flexion, extension, abduction, adduction, medial rotation or internal rotation, lateral rotation or external rotation. Planes and axis, learn it. Now is the arthrokinematics. So osteokinematics, when they ask you about osteokinematics, you have to write about the movement and the plane in which it is taking place. But when they ask about arthrokinematics means the minute movements occurring inside the joint which are not visible by the eyes. So it is known as arthrokinematics. And in the deceased condition or any disability of any joint, arthrokinematics are disturbed mainly. So regarding the flexion, so it is posterior spin. Posterior spin happens in flexion. So this is the acetabular fossa of the hip joint. So if this is the femur, then to make flexion, that means you have to take this head of the femur ahead. You have to move the femur in the anterior portion, then this neck will spin posteriorly. So spin means that the joint, it doesn't change its position, but it only spins around that position. So this is one thing, and normal flexion is 120 degree. Extension, anterior spin. Always remember, flexion, movement is in anterior portion, so spin will be in posterior direction. Extension, movement is in posterior direction, so spin will be in the anterior direction. So this opposite relation, you can remember it easily. Normal angles you can remember. Then is abduction. So see, in abduction there is roll and glide. So roll means joint, it moves forward as well as it spins. So this is known as rolling. Then glide. So glide means it moves forward. So this is known as gliding. So in abduction, there is roll superiorly. So we know common sense that suppose this is the head of the femur and we have to abduct it. So head of the femur, abduction means it is going here. So obviously the roll will be in the superior direction, as this arm will move like this. So the roll will be in the superior direction and the glide will be in the inferior direction. So this arthrokinematics you have to learn separately to understand what I am telling. Then the normal angle is 45 to 50 degree. Then adduction, the roll is inferiorly but the glide is superiorly. Opposite relation here also, you can remember it by this. See, this arthrokinematic thing is very important in your exam. Whether you understand it or not, main important thing is that you write it as it is in the examination hall in the answer sheet. But I would suggest you that please understand the basics of arthrokinematics so that you don't have to mug up the things. Medial rotation is anteriorly and glide is posteriorly. You can do this by your own. Do medial rotation of hip joint and you can check that the rotation happens anteriorly whereas the glide happens posteriorly. Whereas in lateral rotation, the rotation happens posteriorly whereas the glide happens anteriorly. Normal angle is 42 to 50 degree. We have completed open chain kinematics or open kinematic chain of hip joint. Now let us move on to the closed kinematic chain. So in closed kinematic chain, the head of the femur doesn't move. Here the pelvis moves over the head of the femur. Got it? So the proximal segment is moving. Here the distal segment was moving, whereas in CKC the proximal segment is moving over the distal segment. So it includes pelvic tilts and rotation. So firstly let us cover the tilts. So the pelvic tilt include anterior pelvic tilt. So anterior pelvic tilt happens in flexion. So when we bend forwards with pelvis, so see, here we are doing flexion of the spine or the pelvis. So here there is anterior pelvic tilt. Here the proximal segment is moving, not the distal segment, as the distal segment is fixed here. The open surface to move is the pelvis. So this is the thing. So anterior pelvic tilt happens in flexion, bend forward with pelvis. Axis sagittal plane, frontal axis. Anterior rotation and inferior gliding of pelvis over femur. Concave on convex. So this is concave convex rule, that convex surface is stable, concave surface is moving. Concave surface means acetabular fossa. Convex surface was head of the femur. So anterior rotation and inferior gliding of pelvis. Again arthrokinematics, motion is flexion. So pelvis move closer to femur, the angle decreases. So as this is the head, our head, this is our body. So this is the movement. We are touching the ground. So this angle is decreasing as we are moving close. So pelvis is moving towards femur. As you can see, this is moving towards femur and the angle is decreasing. Then comes the posterior pelvic tilt, which means we bend backwards with pelvis as we do in chakrasans. So posterior pelvic tilts, sagittal plane, frontal axis, posterior rotation and superior glide of pelvis over the femur. Motion is extension. Pelvis moves away from the femur, described in earlier diagram. So here we were doing flexion, now we are doing extension. So here this is our body, this is our pelvis, and this is, so here pelvis is moving away from the femur, so this angle is increasing. So this is extension, this is extension. So this is posterior pelvic tilt. That the previous one was anterior pelvic tilt. Now is the lateral pelvic tilt. So lateral pelvic tilt, it happens in unilateral stance. So stance means the position of standing, and unilateral means a single leg, one leg standing. So when we stand on our one leg only, then there is a lateral pelvic tilt. So axis, frontal plane, sagittal axis, load. So when we take entire load on one limb, as the other limb is not in use, and offload other, use is dynamic state and static state. So in which conditions we use unilateral stance? If we are moving, which means dynamic state, so we use unilateral stance in walking, running or climbing, and in static state we use it for standing on one leg. So dynamic, static are the two states of uses of lateral pelvic tilt or unilateral stance. For example, when we climb stairs, so imagine you are climbing stair at lower steps. So suppose this is the steps and we are standing here. So this is our leg, and while this is the lower step, and while we want to step on the higher step, we put entire load on this lower leg, and then we step onto the another or the higher step. Left leg is load bearing, this one is load bearing, and right leg is lifted. So this is right leg which is lifted. Then the left leg goes in pelvic drop, as we can see in this diagram. Suppose this are the stairs, so this left leg was on the lower step which is going under pelvic drop, and this is under pelvic hike which is on the upper step. So as we can see that the leg which goes into pelvic drop, the angle is greater than 90, whereas the leg which goes into pelvic hike, the angle is less than 90, the angle between the pelvis and the femur. So the leg which is on the lower step or in the pelvic drop, it does the abduction. So it happens in lower step leg, whereas on the leg which is on the upper step or which is in the pelvic hike, it does adduction, as the angle is less between the pelvis and the head of the femur, so it is nearer to the body. And we all know the definition of adduction and abduction. So adduction definition is movement of the leg towards the body. So here also the angle is decreasing between the body or the pelvis and the femur, so this is known as adduction. So what is ipsilateral and contralateral? So ipsilateral means on the same side of the body, whereas contralateral means opposite side of the body. Then let us understand what is bilateral stance under this pelvic tilt, which is lateral pelvic tilt. So lateral pelvic tilt, it occurs in unilateral stance also as well as in bilateral stance also. So in bilateral stance, when both limbs are on ground, one leg is flexed at hip joint and knee, partial weight bearing. So it is leaning on an object while standing. So suppose imagine that this is your body and you are standing, and this is your leg and you are standing or you are leaning on something. So you are flexing your hip joint also as well as your knee joint also. So this is bilateral stance example. So it is used in normal gait pattern also while walking. So transfer of weight from one limb to another easily takes place with lateral shift. So as you can see here that when we lean on any object, so the angle between the body and the head of the femur, it increases, so it goes into abduction, and the other leg goes into adduction, angle decreases between the body and the femur. Now comes pelvic rotation. So this is fourth motion of CKC. So this is pelvic rotation. So there is forward or anterior rotation, backward or posterior rotation. So in forward or anterior rotation, it occurs in other limb, whereas backward or posterior rotation, it occurs in leading limb while walking. So this is a reciprocal movement with shift in COG, with shift in center of gravity from one limb to another limb. So pelvic rotation, when we walk, so the limb which is leading, the limb which we put forward, firstly, it undergoes backward or posterior rotation, whereas the limb which remains backward, it is undergoing forward or anterior rotation. So this is a reciprocal movement, which means that there is continuous alternation with shift in center of gravity. Then comes pelvifemoral rhythm. This is important question for 7 marks as well as in 15 marks, similar to scapulofemoral rhythm in the shoulder joint. So pelvifemoral rhythm is also known as pelvifemoral motion. So bones included are, it is a coordinated movement between pelvis, femur and spine. Range of motion, it allows greater total range of motion than any single segment alone. So why pelvifemoral rhythm is important? Because it increases the range of motion. Rather than any single segment usal, it combines all those and it gives more range of motion. So it is similar or analogous to scapulofemoral rhythm of upper limb, shoulder joint. Components of the movement. So as we know, hip joint. So hip joint is the movement of femur on pelvis. So here it is OKC. Pelvic motion, anterior or posterior tilt on femoral heads. So components which includes pelvic motion. So pelvic motion, anterior or posterior tilt on femoral heads. We discussed about it earlier. Then lumbar spine. So it undergoes flexion or extension of the spine. So all these three combine to produce smooth trunk flexion or extension. Hip, pelvis and lumbar spine. So what is the sequence of movement? So suppose we are imagining forward bending, forward flexion let's say, which is initial phase. So in initial phase, pelvis tilt anteriorly, hip flex, and lumbar spine starts flexing. In the middle phase, combined lumbar and pelvic flexion continues. In the end phase, maximum anterior pelvic tilt happens and lumbar flexion is reached. Then in the return phase, means we are going from forward bending to normal position. So according to the language of book, we are going into extension. It occurs in reverse order. Again, the lumbar extends, pelvis tilt posteriorly, and the hip extends. So, what is its quantitative contribution? So, during passive straight leg raise, pelvic tilt is equal to 30 to 46% of the total motion. So, among these, pelvic tilt contributes maximum. Then, during active hip flexion or marching, pelvic tilt gives 80 to 32% of the total motion. So, here passive is greater than active, and it shows variable but constant coordination between pelvis and femur. What is its functional significance? So the functional significance of pelvifemoral rhythm is that it increases the range of motion of trunk flexion or extension. It provides smooth coordinated movement between spine, pelvis, and hip. It reduces the stress on lumbar spine and hip joints as the work is done by all three components. Not any single component is made to do the work alone. Then it helps in bending, reaching, lifting, gait, and maintaining the balance. Then OKC, CKC, so it is important in both open chain as well as closed chain. So open chain includes leg raise and closed chain includes trunk flexion. So this diagram, so this is a example of closed chain and this is the example of open chain. So here we are doing forward bending. So as we can see, there is hip flexion, then there is lumbar flexion, hip flexion, lumbar flexion, then there is thoracic flexion also. This is anterior pelvic tilt. So it increases the range of forward flexion due to pelvifemoral rhythm. It permits hands to maximize the reach towards the ground. So this is the thing. And then in OKC, the person is lying down and then he is moving his one leg. So it increases the range of movement of foot in air. So here it is hip abduction and there is pelvic hike. So integrated close kinematic function of hip, pelvis and lumbar spine. So you have to learn this table. While anterior pelvic tilt, we know there is flexion, the lordosis increases. In posterior tilt, there is extension, lordosis decreases. In lateral pelvic tilt, drop or hike, there is adduction or abduction. In forward rotation, there is medial rotation. In backward rotation, there is lateral rotation. You have to learn this table and write it as it is in the exam. Now let us move towards the kinetics. So as I mentioned earlier, in kinetics, we don't have any relation to the movements. We have to write about what causes the movement. So here we are writing about ligaments. So ligament includes the first ligament, which is the ligamentum teres, also known as round ligament or ligament of head of femur, which stabilizes the hip joint in semiflexion and adduction movement. Then is the iliofemoral ligament, which I have shown here. So it is Y ligament of Bigelow. So it is strongest ligament of the body and it stabilizes hip joint during hip extension. So as you can see, this is iliofemoral ligament. Then is the pubofemoral ligament, which is tensed under extension and it prevents the distraction of the hip joint. So here this is the pubofemoral ligament in the figure. Then is the ischiofemoral ligament, which is weaker. It is tensed under extension and prevents distraction of hip joint. So in this diagram, you can see this is the ischiofemoral ligament. So this is tensed under extension. So this is at the posterior side of the hip joint. Now the passive stabilization through capsule and ligaments. So generally capsule and ligaments can take 2/3 of the compressive load due to body weight. Rest of the weight is taken by the bones as well as muscles, but 2/3 of the weight is taken by capsule and ligament. If more force is required, then muscles are required, as I mentioned. So clinically, flexion and adduction, their hip instability, and least tension is there when there is loose back position, as we discussed in the starting of the video, when there is hip flexion, abduction and medially rotation. This is known as frog position, as I mentioned. So intra-articular pressure decreases in this loose back position and there is less tension. So now comes the load bearing. So load bearing question can also come in university and you have to draw this kind of diagram. So see here, on the head, body weight comes as the acetabulum is there here. So body weight comes here. Then here is the tensile force. So you should be aware regarding which type of forces are there. So you should understand the basics of biomechanics. Then here it is compressive force which is acting in this direction. Then here is the ground reaction force. So this is basic physics which everyone knows. Got it? So these were the force components. Now here is the trabecular system. So trabecular system is the arrangement of bone structure. So this is the trabecular system of at the hip joint. So basically this is present in the femur. So as we can see, this is the primary compressive trabecular system. Here it is primary tensile, and here it is the zone of weakness. So this is the zone of weakness. Here it is the secondary compressive. This one was primary, and here it was primary tensile, and here is the zone of weakness. So this you have to learn and you have to draw in exam. So this is the trabecular system which withstand the stress. Got it? Then is the medial trabecular system which is aligned vertically. It resists compressive load. So as we can see that compressive force or compressive load comes like this. So to oppose that, the trabecular system should be arranged vertically. Resist compressive load. Lateral trabecular system is horizontal and it resists tensile force. So as we can see, tensile force acts in this direction. So to oppose that, the trabecular system should be in horizontal direction. Then is the zone of weakness, which is here. It is the trabecular system is absent in that part. Femur neck. So femur neck fracture is most common. So if they ask in clinical questions that why femur neck fractures most commonly, so you should write that the trabecular system is absent there, which creates a zone of weakness in that part, and you can draw this diagram. Yes, now is the bilateral stance. So bilateral stance, as you can see, I have drawn a good diagram here, and you can see the force components. So here is the weight of hat. So hat is head, abdomen, trunk. It is the abbreviation for that. And this side force is acting, and here it is gravity also is acting, as well as weight of hat is also coming. And this is the direction of the acetabulum, as I'm showing this with arrows, as well as the head of the femur. So this is the diagram of bilateral stance. Now let us move towards the unilateral stance. So in unilateral stance, entire body weight is supported by only one lower limb. So we discussed earlier in this video about unilateral stance. So that was this one. So that was under pelvic tilt. Now this unilateral stance which we are learning, it is under a separate topic, which is unilateral stance. So important during walking, running, one leg standing, basic we have done. Center of gravity shifts over supporting limb to maintain equilibrium, also done. Head, arm and trunk load, HAT, produces a downward moment about the hip joint of the stance leg. So this is also easy to understand. Abductor, to prevent pelvis from dropping on the unsupported side. The hip abductor muscle, mainly gluteus medius and minimus. So gluteus minimus and gluteus medius prevents the pelvic drop in unilateral stance. So this you should understand from this slide. Then it contracts strongly to create a opposing counter moment. So if abductor muscles contract, it prevents the pelvis from dropping. Lever. This forms a first class lever system where fulcrum is the hip joint. Effort is produced by abductor muscles, and load or resistance is the weight of hat and opposite leg. So basic lever concepts you should be aware, and what is the first class lever, second class and third class, or first order, second order, third order. You should be knowing this. Again, this is the diagram of unilateral stance. So here body weight, that is hat weight, is coming. So this is the joint reaction force to maintain the contact. This is the muscle action of hip abductor. So hip abductor muscles contract and the joint reaction force also acts. So there is a resultant which acts in this direction. So due to gravity as well as this group of forces, there is a total reaction which causes a adduction moment, so that the hip joint or the cavity as well as the head of the femur remains in contact. So now is joint compression. So in unilateral stance, joint reaction force is 2.5 to 3 times the body weight. So as we know that only one leg is taking the responsibility to balance the body, so the joint reaction force also increases. So this force increases 2 to 2.5 to 3x means times. So it is due to combined effect of body weight and strong abductor contraction. The increased compressive force stabilizes the hip but may cause pain in pathological condition. So if we maintain a unilateral stance in pathological condition, there may be stability but you may get pain. So let us see the clinical part. So when there is a weakness in hip abductor, it causes pelvic drop. As we know that hip abductor contraction prevents the pelvic drop, but if hip abductors are weak, it cannot prevent the pelvic drop. And as we can see this in this diagram, this is the pelvis and hip abductors are weak, so it creates a pelvic drop, and such kind of gait is known as Trendelenburg sign. So use of an assistive device such as cane in the contralateral or opposite side hand can be used, so can decrease the abductor muscle force and thereby decrease the hip joint compression. So such kind of questions are also asked in university papers. I have seen PYQs. So they ask that if suppose hip abductor muscles of left side of the hip joint are weak, so in which hand should you hold the cane? So you should always hold the cane in the side opposite to which your muscles are weak. So if my left hip abductors are weak, I'll hold the cane in my right hand so that the opposite hand can decrease abductor muscle force and thereby decrease hip joint compression. If it is used on same side, which is ipsilateral, compressive force increases and further degeneration can occur in the hip joint capsule. So now muscles of hip joint basic. Flexors, primary flexors means which primary means the main, and accessory or secondary. Main muscles are the main which initiates the movement, and accessory means which contribute to that movement. You can call them as synergist also. So primary flexors are iliopsoas and sartorius. Secondary are pectineus, adductor longus, magnus, adductor magnus, as well as gracilis. Primary extensors are gluteus maximus and hamstrings. So hamstrings in active insufficiency, when hamstrings goes into active insufficiency, in the position when hip is extended and knees flexed over 90 degrees. So as I have mentioned in my shorts of active insufficiency versus passive insufficiency, I have given this example. You can go and watch that short. Then is abductor. So primary abductors are gluteus medius and minimus. So gluteus maximus is supportive. If abductor is weak, so lateral leaning or pelvic drop, this gait we discussed. Then is adductor. So adductors are adductor brevis, adductor longus, adductor magnus, pectineus, as well as gracilis. Then is lateral rotators. So lateral rotators include obturator internus, obturator externus, gemini, superior and inferior, quadratus femoris, as well as piriformis. The medial rotators are gluteus medius, gluteus minimus, and tensor fasciae lata. Tensor fasciae lata, or the continuation of tensor fasciae lata, is also known as iliotibial tract. This is a part of anatomy, I hope you know. Then is medial rotation. During medial rotation, torque increases with increased hip flexion. So this type of gait is known as crouch gait due to hip flexor pathomechanics instead of adductor spasticity. So in this kind of gait, there is hip flexion as well as some part of medial rotation. Then is pathomechanics. So pathomechanics includes osteoarthritis due to constant wear and tear of hip capsule. It causes degeneration, hip abductors, snapping hip syndrome or iliotibial tract or tensor fasciae lata syndrome. Length tension relationship is altered and tensor fasciae lata rubs over greater trochanter in sagittal plane, which causes a snapping sound. So what happens, that length tension relationship is altered and TFL rubs over greater trochanter. So as the TFL or IT rubs over the greater trochanter, it creates a friction and it creates a snapping sound. Then is piriformis syndrome. So in this, sciatic nerve compress under piriformis muscle. It radiates. There is a radiating and tingling pain from gluteus to toe at the dorsal sign. So this is piriformis syndrome. And yes, we have completed our hip complex in one single video, one shot, and I hope that you have understood all the hip complex terminologies as well as all the concepts in this single video. Yes, thank you. Don't forget to like, share and subscribe for more such videos.